If you'll take your seats, we'll go ahead and get started. Nancy, Cynthia, Mr. Franklin, let's get started. So I want to welcome everybody here this evening. I'm Mike Giesland, President and CEO of Central Health, and this is an important event, not just for Central Health, but for the community. And we brought you here today because we had a third party come in and do a performance review of Central Health. And typically whenever organizations, especially government organizations, you go through a performance review and it's comprehensive, you take this performance review and you start picking and choosing about what you're going to do. Well, we want to take a completely different approach, and we want to bring this review back to the community. And that's why you're here this evening, is to help us start working through this report and determining what is it that we work into our strategic plans. What is it that we just need to do at a managerial level? But we want you to really think critically, and you can assume that you're a Central Health Board manager, you're going to assume that your staff, or just be whoever you want to be, but if you were in our shoes, what would you be thinking right now? So before I turn it over to Germain Solutions, I want to give a little bit of background around this report. Central Health, because of the way we were created and the way that we've inherited a lot of our infrastructure, so think about the fact that the city ran Brackenridge for a while, and then it was ultimately transferred and conveyed a couple of times, and so we have the relationship that we have now with Seton. Think about the clinical systems, about how those were in those health centers, how those, before there was Central Health, they were run separately through city and county. Well, those ultimately conveyed through Central Health. And so when you see how we've evolved, we're rather unique compared to other hospital districts around Texas. And so it made the review of Central Health a little bit challenging, and I'll let the review firms speak for themselves on that. But we're a unique animal as far as hospital districts go. And so with that, what you'll hear from Germain Solutions to talk about what makes us unique and some of the challenges that we have as we move forward. Again, before I introduce Tracy Kulik to come up, you'll be broken up into groups, and there's going to be some more orientation here before we break up into groups. But I want to go back to something that I said earlier. This is extremely important to us because you as the community are helping us make decisions that are not just going to be felt next fiscal year. They're going to be felt for several years to come, because we realize that we're setting a new course here and we want to make sure that we get this right. So don't underscore this meeting or what you have to say, or underestimate what you have to say. It is extremely important because it's helping us determine the future for the low income and the uninsured in Travis County, whom we are privileged and proud to serve. So with that, I'll turn it over to Tracy Kulik from Germain Solutions. Tracy?
Thank you, Mike. I'm so glad to not be on that big TV as I was on the other presentations. I don't mind presenting, I mind seeing myself on the TV. What we're going to do is present the same presentation that gave a summary overview of our performance review, that we just had finished conducting. It went from mid-July through basically the end of January. And a lot of the comments that Mike made, I'm going to echo. Do I have a little thing right here? Thank you. So I'm pointing, doesn't matter? Okay. So just to introduce our firm, Germain Solutions, we're a public health research firm, and we specialize in health access and deal with a lot of public health entities throughout the country. And you're going to see in one portion of what we did quite a bit of benchmarking, as Mike indicated, and found out how very unique you are. There was some ability to benchmark you to portions, but the partnership spirit or basic entity that you represent was really pretty unique throughout the country. Even people that have some partnership had ownership of part of their entities. So, and you'll see that that's both a blessing and a curse. We're going to go through the findings of the performance review. And specifically, we did an assessment of the actual entities and then the affiliated entities. And we used an assessment tool that looked at where you were currently, but because of the unique point in time that we did this, you had a new CEO, a number of new board members, and many things were already in process when we started. So we also did an assessment of if things continued with what you had in place, what would that look like? And, you know, to your credit, it resolved a lot of the issues in the current assessment tool. And then we did the benchmarking, and we just finished and just submitted a 3-week period in which the public could ask questions of us via email. Although that's something, you know, I know Central Health is open to and wants to kind of consolidate with this community forum. So our efforts at public input, we did have 2 focus groups, and we'll state right away those weren't that well attended. Part of the issue, I think, was it being a performance review and what people think that that entails. We've heard interpretations as broad as an audit, which it is not. That's really a specific type of assessment, and a performance review was just that. We heard things like a community health needs assessment. I have worked in your community, although I'm from Atlanta, since 2002, and you have to be the most assessed community I've ever met. Back in 2002, I did a needs assessment here, and the providers all universally said, yeah, we'll work with you, but we're doing 5 other needs assessments at the same time. Can't you people all get together? Well, it was different federal funders, different focus points, but there is a real opportunity for that. However, this performance review is not a needs assessment. What it is actually looking at the entities in Central Health and saying, how do they compare to other like entities, both in Texas and nationally, but also what is the investment that Central Health is giving to those entities, and what was the desired output, and how is that working? So in addition to the focus groups, we did an extensive review of those needs assessments and of your very many surveys. We had surveys that we reviewed, and we have a specific piece that we've just submitted to Central Health that you can look at that summarized all the community outreach and engagement, and particularly the surveys. We reviewed 8,000 surveys and those comments, and they were very telling, but also very specific and repetitive in their findings, and we'll go over that in the assessment. And then we had stakeholder interviews. We interviewed all the Board of Managers, all the Central Health executive staff, the entities that are directly funded by Central Health and those that have contracts with them or affiliate enterprise entities, and some contractual partners. So it was roughly 50 interviews we conducted. And then we did our actual internal assessment. These areas that we looked at, the 6 domains, think of these as categories. We had access, communications outreach, planning and budgeting, population health, funds flow, and organizational governance. And those were the 6 categories that we examined central health in relation to. One important clarification here, and again, this becomes a very complex entity because of the partnership nature, is that review is of central health itself. It is not a review of those specific enterprises, in particular community care collaborative, the FQHC, and then the partnership with Seton, or any of the contractual entities, Integral Care, those individuals. Those were beyond the purview of what we were reviewing for performance, but we were reviewing in central health's investment or funding of those entities, what did it submit, what did it give to them, and what was the intent? What did central health expect to get back as far as outcomes? Underneath those 6 domains or categories were 15 basic indicators and 46 performance measures. This will make more sense when we go through some of them. And then, again, we did the benchmarking analysis to the 6 Texas public health authorities. And we looked at 13 national health districts, 10 responded, which is actually a really good response rate. And then we also conducted a literature review. So here's another way of looking at those categories and the ability to start saying what some of our findings were. In communications and outreach, we're looking at how central health interacts with and conveys information to the community. We found in this that there was a lot of, almost overwhelming information that's put out there. However, part of it, even on the website, which is amazingly populated, presumes a base knowledge of who central health is and how they interact, and also is kind of complex and overwhelming. One of the main findings we had in communications outreach is the need to better brand central health. Now, I'm going to date myself from a child of the 50s, but my corollary to this was like the BASF TV commercial. We don't make the plane, we make the jet fuel that goes into the plane. Other people who are more millennials thought Intel inside or General Electric. These are suppliers to people who directly provide a service or a product. That seems a very simple message, but it's really complicated to explain because you are not the direct provider. But you are an important and an integral part of what those providers can do, largely because of another very complex topic that's in our funds flow. As central health and as a taxation public health district, you're allowed then, or one of your big opportunities or missions, is to help fund entities through the intergovernmental transfer. And anyone who immediately understands an IGT in any state is probably, a PhD. It is difficult to track all those funds flow and how matching funds work. But one of the big findings in funds flow was what we expected somewhat at the outset, and we found in that with the partnership model, it's hard to track those funds that you maximize from the federal and or state government and how you have outcomes from these different partners who directly provide services. What we found, and some of you even commented on this in some of your questions in your tenets, certainly in the interviews, was that you were pretty good at tracking processes, how people did things with those monies, but not necessarily what happened as a result. And that, I think, is one of the big messages here, is to be able to use this wealth of information you have and say, what exactly did you improve in the community based on this? So we see two linked messages. One with communications, that we need to have a better high-level explanation of what central health is before we get into all these really complex things like intergovernmental transfer, but also with more information technology, which there's been quite a bit invested in that, and with better agreements with these partners to be able to say, what impact did we have in the community? Did we help prevent diabetes? Did we help better treat diabetes? Did we do that? And here's another message that links communications, outreach, funds flow, and population health. Did we do that for key segments of the community that are either underserved, underrepresented, or who don't know what central health is? In particular, we looked at the Latino population. And some of the minority populations, no entities that central health helps fund and really, makes them be able to deliver their mission, like community care, the FQHCs, but they don't know central health. And so linking that and showing them how these resources help those important service providers attach people who would otherwise not have care or that aren't aware of central health is really a conjoined mission here. We saw with planning and budgeting that this was an area you were benchmarked throughout the country. And I think anyone who goes on the website or sees how this is an ongoing, most public health authorities, it is a good part of their year, maybe 4 to 6 months. With you, it never stops. This planning and budgeting are really inextricably linked because of some of the partnership and the funds flow mission. And this is an area you are very, gold star. You achieved the best status of this. You're very transparent. Again, I would say, though, possibly to a fault, in that there is so much that's out there on the website or that's explained to the community in an effort to be transparent, that this high level, who are you and why do you exist, is assumed, but not necessarily known. And so one of the things that we gave as a strong recommendation was to take a step back, really do a better job of branding who is Central Health and how they make this community be able to spin, but also say, what is the outcome? What's the accountability? What did you get done that couldn't have been done? And you almost have to have this odd case where you see this a lot in public health. You have to say, what if Central Health wasn't there? Then what would happen? And it's pretty significant, almost drastic, when you see what would happen there. But you see, that's another message that's very difficult to convey. On organizational governance, we did find some areas that in the current assessment were lacking, but with what's in process are much better addressed. With Mike coming on board, a CEO evaluation tool, some issues about term limits for board members, because there's some that have been there since Central Health started, which shows a lot of dedication, but may become an issue. And also a stronger conflict of interest policy. So the other thing we did, and this gets pretty intense, but a lot of this information is going to be on the website. We not only ranked on these 6 domains, 15 indicators, and 46 performance measures, but we also said what is a low to a high performance and what is time sensitive. And we ranked all the findings by that. So something could have been a low performance and needs to be attended to, but it wasn't time sensitive. So in summary, you performed over, or Central Health performed above average on the internal assessment, and the disparate management and a lot of the funds flow in a complicated federal, state, local funding triangle was superb. One of the best that we saw in the country, and we looked at DSRIP in other states. DSRIP is Delivery System Reform Incentive Payment. And it's the effort of largely Medicare to improve both the quality of individuals, of the community, and lower the cost. Now, sounds like a simple message, which is a triple aim, but it's very difficult to do. And you've done that very well in a lot of your projects, funneled through Central Health, but with a lot of partners. The lowest average rating, which you're going to hear about in one of the breakout groups, is specialty access. Now, you are not unique in this. There's one of the benchmarks, one of the 10, that actually has been able to address this or start to conquer this. But whole communities agonize over specialty access, not only having sufficient specialists, but the wait time to get into those. And certain specialties were much more of concern. Your partnership model, again, can't stress this enough. It is the pure element of who you are. And I will say, to the good, it really does focus Central Health in a unique way on principles. Why do you do this? What are you trying to do to be able to improve access for health services, particularly to the indigent population? You don't have those very complicated things get in your way, like owning a hospital, unionization, keeping the costs down, worrying about the demand of that, your payer mix. However, you don't have a lot of control. And when you look at where you do have control, it would be in more of these complex funding interactions, and you don't really want to press that button. And so one of the recommendations was to have stronger agreements with your partners, primarily about data, timely, accurate, detailed data that shows outcome versus process. And that is, again, a simple message that's very complicated to do. You do have a flexibility, but again, that day-to-day control you don't have. Of all the 10 national and even the 6 Texas, they all own some or all. Many of them own the hospital. You don't have full influence, and we said this, both into the funds flow or all of your legal implications. Again, blessing and a curse. I would say it is unique in that you hear not only from all the key informant interviews, from the surveys, you hear this from the executive staff, a real focus on the principles of why you're here, which gets lost in a lot of organizations that have to be concerned all the time about the day-to-day operation of entities, particularly a hospital or a health plan. You do have, though, this become difficult, as we said, Intel Inside, BASF, or GE, for the community to understand. I think the physician shortages is an issue, specifically specialty access, but many of the questions brought up, what about primary care access? Very worthwhile focus. And then we did talk about other means of leveraging financial resources, in particularly federal grants or some kind of philanthropic entity. Federal grants, though, a caution on this, I do a lot of these. It's very important that you, in your partnership, pure model of principles, make the grants work for you and not the other way around. There's a tendency for that to flip on you. So this is just to show you the benchmarks in Texas. This is to show you the national ones. And I am closing per my time. But the key thing here, I think, is as far as benchmarking, access was, again, a gold standard, as was planning and budgeting. There was communication was good, but could be improved, especially with minority communities. Population health is a complicated issue by itself, but the partnership model and who exactly within those entities was doing population health was a concern, as was specific focus on certain disproportionately impacted, particularly minority communities. Governance is very prescribed at Central Health. I think there were some refinements to it, but overall it was good. And then the funds flow is very dependent on the tax base and on complicated financing mechanisms. So, am I on time? Hey.
There was a bit of a typo on the agenda, so I'm going to go ahead and pass some of these out. There's a date that's missing at the bottom, and I apologize for that. But we do want you to make sure that you know about it. I'm just going to pass it out. And next, I'd like to talk to you guys about the interactive portion of this community conversation. My name is Ivan Davila. I'm the Manager of Communications and Community Engagement here at Central Health. And the interactive portion is going to follow now. And each of you have received a note card with a number when you walked in, okay? And what that means is that's going to be the group that you're going to be part of, okay? And I'm going to go ahead and tell you who your facilitator is, and then I'm going to tell you where you're going to go after this. You're going to have... No problem. Okay.
Hello, everyone. My name is Guadalupe Zamora. I have the great honor to be the chairman of the board for the next 2 years here at Central Health. But we have a quorum of our board members here now, so I have to call the meeting into session. So I'm calling the Central Health Communications Conversations, Improving the Health of your Community, March 19th, 2018 at 5:30 at Central Health Administrative Offices, 1111 East Cesar Chavez, Austin, Texas, 78702. And with that, let's start the meeting. Thanks, everyone. It's an honor to have everyone here. We have a great organization, and hopefully we'll learn some more. Thank you.
Thank you, Dr. Zamora. Okay, so the interactive portion of the community conversation. So we're going to break people into 4 different groups, and each group is going to meet in a different room, okay? Before we do that, I'd like to just go over a few ground rules because we do want to stick to the discussion at hand. So first and foremost, we want to ensure that we do active listening to better understand various perspectives, okay? That we respect each other's right to speak without interruption, that we be aware of how long and how often we speak so that everyone has an opportunity to contribute. Each group is going to have between 6 and 8 participants, and no personal attacks. We want to make sure that it's a productive conversation. We want to use inclusive language. We want to be committed to helping develop solutions, both short-term and long-term. And each facilitator will remind you of that if anything happens. But we also want to make sure that we stick to the discussion. Each group is going to be talking about a particular finding, one of the findings that Tracy spoke about. Oh my gosh, here we go. Do I need to repeat myself? No. Okay, so if you have a number 1, group 1, then you're going to stay here in the boardroom, and Monica, you want to raise your hand, is going to be your facilitator. And then if you have number 2, then you're going to go next door, okay? And Sarah, you want to raise your hand? Sarah's going to be your facilitator. If you got number 3, then Mike, would you like to raise your hand? I thought I was 2. Okay. Excuse me, Mike is 2. Mike is number 2. Okay, and Sarah is number 3. And if you got number 4, then Ted over here is going to be your facilitator, and you're going to be in the lobby. Okay? So number 1 is going to stay here with Monica, and we're going to be discussing the issue of private and public partnership. Okay? Number 2 is going to be Mike here, and we're going to be discussing diversifying our funding sources. Number 3, Sarah is going to be discussing specialty care access. Okay. Number 4, Ted over here, we're going to be discussing issues about communications, community engagement, and outreach. Okay. We're going to have 45 minutes to hold this discussion. There's going to be a note taker, and the reason I'm stressing the importance of sticking to the conversation is because we're actually going to be taking notes, and we're going to be developing a report. It is very important. And we're going to come back, and if the facilitator will name a spokesperson, or a spokesperson will volunteer, then when we come back, we're going to have 5 minutes for each group to report out to the group, okay? Have fun. Thank you. like to get started shortly, just so that we can respect everybody's time. Please feel free to take your seats. Cheryl?
Little shit.
Everyone, please feel free to take your seats. We're going to get started here shortly, in just 30 seconds. Do we have anybody over there? All right, is everybody settled in? I want to thank you all again for being here on a Monday evening after work when you could have been at home with the family. You fought Austin traffic to get here, so again, thank you so much for being here. We're going to get started with a report out session. And I want to have a show of hands of, I just want to see who our spokespeople are. Who are our spokespeople for each group? I don't have my glasses on me, I'm sorry. Mia, Delfina, Mia, Joanna, and who else? There were 4 groups, so we have 3 so far. Oh, group 1 doesn't have a spokesperson. Can we pick one? Oh, we do. Okay. Mr. Moody. All right, let's go ahead and get started. And because we're just running a little bit behind, we're going to give each group 2 minutes. So if you can summarize everything into 2 minutes, that would be great. And we're going to have a timer. Mr. Moody.
We talked about the public-private partnership model, and the first question, which really got us started, was, do we agree with the recommendation? We believe that the recommendation, although accurate on some levels, was too vague. Because the question is, what are we communicating? Are we communicating the model? Are we communicating about central health? Are we trying to talk about the value of central health to the community? So we have to first lay out or delineate what we're trying to communicate, and then when we decide that, we have to go into who we're trying to communicate to. There are levels of providers, there are levels of the community, and so each level is going to require a different type of communication different verbiage and different key points. One person used the acronym WIFM, which means what's in it for me. And every level every person at every level has to have their WIFM addressed. And it needs to be addressed publicly, it needs to be addressed privately, and the providers need to be listed, the healthcare providers need to be listed on some type of form so that anybody who is looking at Central Health will say, these people and these programs have been funded by Central Health. We have to have a company-wide brand, and where all partners that are connected to Central Health say the same thing about Central Health. So we agreed in principle with the recommendation, but we believe that the recommendation itself needs to be clarified because there's so many levels of communication and so many possibilities. Is that 2 minutes? All right.
Thank you, Mr. Moody. Group 2 talked about the specialty or the physician or doctor shortage. And, oh my gosh. Well, no, the group next door talked about the specialty care access. And the key finding was that there is a significant need for Central Health to have a more defined plan to address physician shortages, particularly related to specialty care. Why am I holding too many things? The recommendation was twofold. In the short term, Central Health needs to commit to creating more specialty care access through the use of advanced practice professionals, and when legally available, through the expanded use of technology. In the long term, Central Health needs to work with the city and other institutions to dramatically boost the number of providers in the metro area through initiatives that coordinate expansion of graduate medical education programs that specifically address specialties with the greatest gap between supply and anticipated demand. And for this, we have who from the group next door? Delfina, thank you.
Hi, so we talked about the physician shortage in specialty care. So we had behavioral health, which were clients that don't want to be known because of their criminal history or their social issues. Also co-locations like schools, primary care, specialty care, and behavioral health in jails. Also well care like community needs, lifestyle, neighborhoods, the leverage of physicians to see primary care providers first, or physicians first, team of clinics, practice to the highest use of license, e-consultant, primary care, physician specialists, using protocol, and then also family and friends that are empowered to help the patients, so they can be in the room while they discuss what's going on with the patient.
Thank you. And then the group 2 doors down, they discussed the diversification of Central Health's funding sources, and the recommendation was there are certainly opportunities to increase funding from 2 areas, external grants and philanthropy fundraising. To really support fundraising efforts, Central Health needs to consider setting up its own foundation. That was a recommendation. And who do we have from the group 2 doors down? Mia, thank you so much, Mia.
We kind of got off topic, which is something that I tend to do. But one of the things that we talked about was, why are we trying to reach philanthropic funds when we have $23 million in reserve? And so with that $23 million in reserve, what can we do with it to add to the population's outcomes, as opposed to, do we try and get investors? And so instead of trying to spend the money or to lend the money out or to match the money, let's see how we can take what's in the reserve and get better outcomes. So Central Health had X amounts in 2017 of people who were receiving the health care, and then 2017 was another amount of people. But then if we use our reserve, the $23 million, how many people can we reach if we used most of the money that was allocated to give to the people for proper health care? And so we couldn't get past that. And so one of the things we said is before we reach out for philanthropic help, what outcomes can we have with what we already have? And then another thing we asked is if we ask someone to match the monies that we're giving, what are they going to want in return? And will they be able to tell us where the money goes? And one of the things we were like is like, yeah, they could. But then my issue would be, well, what about if it's not that person's turn or that population's turn to get what you needed out of that funding? And so our thought was, do we want that power in someone else's hands besides Central Health? And then what can we do to expand on what we already get from Central Health in the property taxes and the other funding that we already have? Let's use what we have to see what we can do.
All right, and group number 4. So group number 4 was, the finding was there's confusion among constituents regarding the relationship between Central Health and its multiple affiliates and strategic partners and the value Central Health brings to the community. There is also a disconnect between the community and Central Health's community engagement outreach efforts. The recommendation was communicate the role Central Health plays in serving Travis County residents with low income more effectively. Perhaps a marketing strategy like the Intel Insight campaign is needed so that the community recognizes the value Central Health provides through its network. Additionally, it is essential that Central Health begins connecting its community engagement and outreach efforts to the request of the community in order for the key constituents to feel heard. And we have Joanna, who is the spokesperson for that group. Thank you, Joanna.
Hello. So our group, we discussed a lot of things. We did agree with the recommendations and discussed how Central Health is associated with healthcare, the healthcare delivery system, and that's important. We agreed that education would help informing people, both voters and people who are receiving services, that the relationship between Central Health and the collaborative and all the different programs. Any of my members, please speak up if I leave out anything super important, because we bounced around a lot. Also, we talked a lot about the taxing district and emphasizing the taxing district and what that means as a voter and what that means as a client. We also discussed how important is it as a client to really know where the money is coming from, if in fact you're getting a good service. So at some point, word of mouth is good enough. How many people, will that affect? Not very many, but, that's, potentially a relevant point. We also discussed emphasizing partnerships with schools, community, grassroots organizations, other initiatives that are already going on, and publicizing outcomes, especially community engagement activities like this, because people know that they happen, and we all have this experience here, but then other people can't necessarily follow up, and not even all of us know, what occurred in all the groups. So to be able to report back and be accountable for that information. Let's see. We also agreed that, or it's relevant to note that with the influx of so many new residents, constant engagement is required to inform the voter population and inform new residents, inform new voters about Central Health's role, how funds are deployed, transparency of dollars. Was that a buzzer for me? Sorry, I'm a slow talker.
Thank you, Joanna. And again, thank you all so very much. We do want to be accountable, and so we are going to be sharing this with you all via email, and then we're going to invite you back, and Mike's going to talk a little more about this, for another set of community conversations that we're going to be holding at the Central Health Southeast Health and Wellness Center for those the residents who live south, and then we're going to hold another community conversation on the 5th at the Aldenier High School, also Thursday evening. And so with that, I'm going to turn it over to Mike to close.
We have new save the date flyers that have the actual date on them. So
Yeah, so you're not guessing.
We passed them out earlier.
So as Yvonne said, on April 3rd and then again April 5th. April 3rd is at Southeast Health and Wellness Center, which is here off Montopolis Drive, and then Lanier High School off of Peyton Gin Road. So the question is, how is the meetings on the 3rd and the 5th going to be different from this evening? This evening was about hearing from you all. The next time we get together, we'll start discussing, we're going to take what you've told us here today and start looking at how is it that we would implement some of these strategies and these tactics that we heard Monday evening. And you'll start to see some concepts take shape, not just words that you've spoken, but things that become part of the written record, so to speak, that lead up to what our strategy and our business plan is about how we serve the low income and the uninsured. It's going to start to take shape as if you were a member of the Central Health Board of Managers and you told us, come back with a plan. Well, this is part of that iterative process. You're advocates, you're leaders, but at the end of the day, we're all humans, and I think we can do a good job of taking care of each other and taking care of those that are less fortunate. And you all are very much a part of that process. And it's really motivating to us as staff when we don't have to be out there by ourselves. We have friends, we have community members, we have tough critics that help us make the right decisions. I can't emphasize how important this evening is, not just right now for us as staff, but for years to come. Blessings and safe travels to all of you. Thank you. While he was standing back there looking at me, yeah.
Yeah, it is 7:03. Can I get everybody's attention? Just 1 second. Give me 1 second. Hello. One more minute before you leave. I just want 1 second of your time because I want you to see the future of medicine. Raina, come up, please. Raina came to listen to us, what we were doing here at Central Health, because she's already advocating what Group 3 was talking about, increasing our healthcare professionals, whether it be nursing or medicine, doctors or whatever, all our healthcare. She is our future of medicine. You're seeing it right here, but she's already going into the elementary schools and telling our children in the 4th grade about STEM, the science, technology, engineering, and mathematics. So thank you for coming. Mr. Gleason wants to speak to you, and I know you already spoke to Mr. Burton, but you are the future of medicine. You are what's going to replace me, because I'm getting old. All right, because we had a quorum here, I had to call the meeting to order. So now I must call the meeting, or close the meeting. But before I do that, I have to announce save the dates. The Community Conversations Central Health FY 2019 Work Plan. The first one will be in South Austin on Tuesday, April 3rd, 2018, Central Health Southeast Health and Wellness Center on 2901 Montopolis Drive, Austin, Texas, 78741. That will be from 6:30 to 8. And then the next one will be, like as Mike said, at North Austin on Thursday, April 5th, 2018, at Lanier High School at 1201 Peyton Gin Road, Austin, Texas, 758. 6:30 to 8 as well. With that, do I hear a board member? Do I hear a second? A second? All in favor, say aye. All right. Now we can go home. Thank you, everybody, for coming. Thank you for coming.
Yeah, he was telling me about it. You're wanting to go into elementary school.